Hello friends. So we were at this question of pediatric limp. Let's look at the answers. As I said, these are the differentials: bilateral slipped upper femoral epiphysis, line of Klein, 3-to-1 sign. Let's move on to the next one. Okay, you can pause the video again, read over it, and write the answer. Okay, so what is the most likely diagnosis? It was very clear that the child is quite stable enough, and from the description, and if you see the purpuric patches, it is Henoch line purpura. And what bedside test is recommended? So the only bedside test you want to do in this patient is a urine dipstick to look for proteins and RBCs. Okay, and what intra-abdominal pathology is associated with this condition? You get intussusception. Some people have also written acute IgA nephropathy, which is absolutely a correct answer, so that is acceptable as well. Next one. So what are the components of traffic light assessment? People have written heart rate, respiration, and some stuff, or some people have just written red, amber, and yellow. The question is asking about what are the components which are mentioned in the traffic light. You should remember color, activity, hydration status, respiratory system, and others. In that comes heart rate and other stuff, but these are the basic 5 components. You should never forget that. Yeah. So color, activity, respiration, hydration, and circulation, and others. And it is green, amber, and red. Green can go home. Amber, you balance between whether you want the patient to be admitted or you want to discharge, and red is definitely admission. Okay. If you can't remember C for color, H for hydration, A for activity, respiratory, and T temperature, or so chart, CHART. Then the next question said, there is no red or amber and it is low risk. The child can be discharged home if a source is established. What advice would you give the parents? So you want to give the fever advice, which is quite simple. Regular fluids, detect signs of dehydration, check the child at night, how to identify a non-blanching rash, keep the child away from nursery or school until the child is not well, and seek medical attention if there are concerns. Who gets antibiotics prophylactically if they are really concerned, or if they are in shock, if there are signs of meningococcal disease or decreased level of alertness. Age less than 1 month, they definitely get it. Between 1 to 3 months, if the WBC count is greater than 15 or less than 5, and in 1 to 3 months who look unwell. So you got to make a proper judgment before giving prophylactic antibiotics. Next one. Okay. So what features may be suggestive of tracheostomy tube displacement? So somebody who's finding it difficult to breathe, shortness of breath, desaturating, somebody who's able to talk with a tracheostomy tube in place, that can suggest that there is a tracheostomy tube which is displaced. You have called for help and attached EtCO2 and oxygen. So displaced tracheostomy tube and displaced endotracheal tube is there in the curriculum, so you should know about both, especially about the displaced endotracheal tube. They ask the DOPE mnemonic: displacement, obstruction, pneumothorax, and equipment failure. So, and in displaced tracheostomy, there is a nice algorithm which you should know. What breathing apparatus you would like to connect to. In the difficult airway society algorithm, they say that you need to connect to a water circuit or Mapleson C. ETCO2 tracing is not squared and chest is not moving up and down. That means the tube is obstructed or is in the wrong passage. So the tube is obstructed or the cuff has herniated over the end of the tube. So I'll show you this chart. So this says hypoxia, cardiovascular instability, cuff leak, and the patient talking despite tracheostomy tube is in place. You will call for help, attach 100% oxygen, check capnography and attach water circuit. And then if it is not showing a good rise, then tracheostomy tube is blocked or cuff has herniated. You need to deflate the tracheostomy tube and remove it, and you need to ventilate them if they are very severely hypoxic. Otherwise, you can put in a new tube. So you can get this algorithm. Just Google in Royal United Hospital Bath displaced tracheostomy and you'll get the algorithm. Next one. Okay, what is the ABG criteria? So less than 200 is the ARDS, and that's FiO2 by PaO2. Less than 200 is ARDS, and less than 300 is acute lung injury. Not ALI, acute lung injury. Okay, three components of ventilator care bundles and lung protective ventilation. So acute lung injury is PaO2 upon FiO2 less than or equal to 300 ARDS. What you need to do to prevent aspiration is, or to prevent aspiration pneumonia in ventilated patient is, you need to give them oral hygiene. So oral care with chlorhexidine mouthwash, propped up position, and subglottic aspiration. So you need to do some suction. Lung protective ventilation is you give them low tidal volume and have permissive hypercapnia. Okay. What do you understand by auto PEEP? Initial ventilator setting, and what are the physiological effects of PEEP? So auto PEEP is the intrinsic PEEP, also known as progressive air trapping. Initial settings would be low tidal volume, low respiratory rate with prolonged expiration time. You need to give them enough time for expiration, so low IE ratio. PEEP can give rise to reduced preload and therefore reduce cardiac output and hypertension. It can cause barotrauma and cardiorespiratory collapse. These are the negative effects. The positive effects is PEEP can help us in preventing the collapse of the alveoli. You can refer to this web link and read that particular section. So the next one is about lumbar puncture. You can pause and write down your answers. Okay, so you have decided to do a lumbar puncture considering a diagnosis of Guillain-Barré syndrome. What are the anatomical landmarks? So posterior iliac crest, the horizontal line joining the posterior iliac crest is at the level of L4 spine. So either one space above is L3, L4, or one space below is L4, L5. You can go, you can make a puncture. Two reasons you would avoid doing an LP in this patient. If there is overlying infection, cellulitis, or and spinal epidural abscess over there, you won't do it. If there is signs of any papilledema or increased intracranial hypertension, you won't do it. You won't do it if the patient is not cooperative or agitated or does not consent. You have successfully done the procedure, sent to the lab. What is the most common side effect following a lumbar puncture? The most common side effect is headache. And how would you prevent its incidence? You prevent it by taking a narrowest needle, putting in a stylet before removing the needle. Okay, making the patient lie down flat, and all these things do not affect, although we practically do it always. So post procedure headache, use a smaller size needle, reduce number of attempts, use non-cutting atraumatic needle bevel parallel to the dural fibers, replacement of stylet before withdrawing the needle. Bed rest, hydration, NSAIDs, position of patient has no role in reducing headaches. This is the link from which it is cited. Okay.